How can bacteria, which are ubiquitous in water, soil, and damp environments, become one of the greatest challenges in modern healthcare? One example is Pseudomonas aeruginosa, an adaptable environmental bacterium that is also a highly significant pathogen in healthcare settings. Few environmental bacteria have developed so many strategies for causing serious infections in humans. P. aeruginosa thrives in moist environments, both natural and man-made, such as those found in showerheads and hoses, faucets, sinks, and drains. These places provide ideal living conditions. Such environments exist in almost every building. However, in areas where vulnerable patients are cared for, these conditions can become especially critical and pose a real threat. What makes Pseudomonas aeruginosa so extraordinary and so dangerous? This aerobic, gram-negative bacterium is no ordinary waterborne germ. It is a survivor, equipped with a whole range of sophisticated defense mechanisms. One example is its use of biofilms. These are protective microbial layers that allow it to shield itself from heat, disinfectants, and the effect of many antibiotics. Biofilms are barely visible, yet extremely resilient. Within them, the bacterium can survive, feed, and multiply, often over long periods of time. A study from 2024 showed that both the faucet and the drain of a hand-washing basin can harbor highly complex biofilms containing potentially pathogenic and resistant organisms. Furthermore, the microbiological composition of healthcare environments differs significantly from that of households. Within, biofilms, P. aeruginosa, can exchange genetic material, further strengthening its resistance mechanisms. This is a decisive factor that goes far beyond the protective function of the biofilm itself. Pseudomonas bacteria have an entire arsenal of survival strategies at their disposal. These include highly active efflux pumps, which transport antibiotics directly out of the cell. They can also alter porins, preventing antimicrobial agents from entering in the first place. In addition, they can produce enzymes such as carbapenemase, which can render even last-resort antibiotics ineffective. They also have a remarkable ability to evolve under antibiotic pressure and develop new mutations. This combination makes the pathogen one of the most resistant bacteria we encounter today. For a period of time, Pseudomonas aeruginosa was classified by the World Health Organization as a pathogen of the highest priority, meaning it was considered one of the most critical threats. Today, it is classified one level lower, but is still within the high priority group. This illustrates how seriously the situation has been regarded. International studies show that P. aeruginosa is involved in approximately 16% of infections in intensive care units. One of the most common ICU-acquired infections is ventilator-associated pneumonia, or VAP. The growing number of multidrug-resistant and carbapenem-resistant strains is particularly concerning. Examples from real-world outbreaks show that this pathogen is not only dangerous in theory. Several hospitals worldwide have experienced outbreaks of P. aeruginosa in neonatal intensive care units, or NICUs, where it was detected in sink drains and faucets. Premature and newborn babies who are especially vulnerable developed severe infections. Splash and droplet dispersion from contaminated washing areas is considered a plausible route by which pathogenic bacteria may reach the patient environment, including areas close to incubators. The scientific literature contains numerous outbreaks involving Pseudomonas aeruginosa, in which hospital sinks and sink drainage systems in particular were identified as environmental reservoirs, including in highly vulnerable settings such as burn units. Patients in burn units, who often have extensive open wounds and moist wound environments, are at particularly high risk of infection. Disruption of the skin barrier combined with an immunocompromised state allows pathogens to invade and persist. These examples illustrate that water-bearing structures are both potential and proven sources of infection. Why do water systems pose such a major risk? Drinking water systems provide ideal conditions for microbial growth, particularly when water stagnates and temperatures between 20 and 50 degrees Celsius or 68 and 122 degrees Fahrenheit prevail. Dead legs and reduced flow rates allow biofilms to develop unhindered. Many of these factors are unavoidable in hospitals. However, contamination does not occur only through the drinking water supply. Several studies show that a washing area can also become contaminated independently of the incoming tap water. This can happen through hand washing by healthcare staff and patients, through contact with patients, through droplets from the patient environment, or via equipment and supplies cleaned in the washing area. This means that faucets themselves can become reservoirs, even if the supplied drinking water is clean. However, one underestimated danger is the invisible aerosol effect. When a contaminated water jet hits the drain, a microbial aerosol cloud can be created. These fine droplets may spread bacteria over several meters. The spray range often extends much farther than the eye can see, beyond the faucet, onto surfaces, equipment, clothing, and even into areas close to the patient. This mechanism played a decisive role in several outbreaks. Aerosol formation occurs wherever water flows. Examples include water systems such as showers, medical devices, including dental units, water dispensers, and fountains. In clinical settings, water-associated transmission can also occur through contact with contaminated water during wound care or through rinse water used in the hygienic reprocessing of endoscopes and instruments. It can also occur via washing areas in intensive care units. In addition, faucets, their outlets, supply lines, and aerators, as well as drains and drainage systems, are often colonized by biofilms. What does this mean for patient safety? The risks are especially high in areas where people with weakened immune systems are treated, such as intensive care units, neonatal intensive care units, oncology units, transplant units, dialysis centers, and burn centers, among others. Even a low bacterial count may be sufficient to infect vulnerable patients and lead to severe disease. When water-associated Pseudomonas occurs, the consequences are often serious, ranging from respiratory tract infections and severe pneumonia to sepsis, as well as wound, urinary tract, and catheter-associated infections. The clinical manifestations are diverse. This pathogen can cause severe, life-threatening, and chronic infections, particularly in immunocompromised individuals. In these populations, mortality rates can be as high as 40%. At the same time, treatment is becoming increasingly difficult due to rising antibiotic resistance. Antibiotic resistance is the key factor that makes many of these infections, and their treatment, so dangerous. P. aeruginosa is naturally resistant and continues to develop new forms of resistance rapidly. Carbapenem-resistant strains, often referred to as CRPA, are particularly concerning and are increasing worldwide. The World Health Organization has been issuing explicit warnings about this for years, as infections caused by multidrug-resistant Pseudomonas are associated with limited treatment options and high mortality. How can water-associated risks be controlled? Infection prevention measures such as consistent hand hygiene, surface disinfection, and the proper hygienic reprocessing of medical devices should be regarded as the minimum standard. In addition, water management plans must be carefully developed and consistently implemented. Systemic measures such as temperature control, flushing programs, and structural optimization are also important, but not always sufficient. Biofilms often remain deep within hard-to-reach areas of drinking water systems and are difficult to remove. For this reason, effective protection is needed directly at the point of use. One of the most striking studies on this topic comes from Germany. Before the installation of point-of-use water filters, 97% of water samples from an intensive care unit were contaminated with Pseudomonas aeruginosa. After installation, that figure fell to 0%. Patient colonization decreased by 85%, invasive infections decreased by 56%. These results clearly demonstrate that systemic measures alone are often insufficient. However, local barriers at the point of use can contain transmission routes and thereby reliably break chains of infection. When used alongside careful hand hygiene and surface disinfection, terminal and inline water filters provide an effective barrier immediately. They offer reactive protection in outbreak situations and preventative protection in sensitive or high-risk areas. They are also useful when the cause has not yet been identified, when other measures are ineffective, or when the underlying causes are difficult to address. In complex water systems, one thing is certain: danger often lurks where it cannot be seen. That is why the most important protective barrier is the one located directly at the point of use.